Chapter 32, Environmental Emergencies. As you can imagine, there are many things that in the environment that can cause medical emergencies. And like many things, there are populations that are at higher risk for these emergencies. For example, children are at higher risk. Perhaps they're not able to deal with poisons or toxins that they encounter as easily because of uh, immaturely developed immune systems. Our elderly population may have a similar problem, but unlike the children, it's not their immune systems are underdeveloped. It's that they're starting to wear out or they have chronic problems. Patients with chronic illness and young adults who overexert themselves, perhaps trying to do too many things without proper hydration and rest. Some of the things that we encounter as environmental emergencies that we'll cover in this lecture are heat and cold related emergencies, water emergencies, pressure related, both high pressure and low pressure, injuries caused by lightning, and envenomation. Environment is complicated, and conditions in that environment can directly affect or indirectly affect how a person reacts to that environment. The earth is amazing, but it seems like there's a lot of things out there that are trying to um, exterminate us. We don't think about cold exposure too much in the Pacific Northwest, but really it is a problem here. We know that heat travels to and from the body in these 5 different ways: through conduction, convection, evaporation, radiation, and respiration. Many of the cold related injuries affect the hands, nose, mouth, or even the whole body. Excuse me, hands, nose, and ears, and even the whole body. With cold exposure, the amount of heat loss or gain can be modified in three ways. You might be able to increase or decrease or have a decrease in heat production. We'll try to increase it first by trying to shiver, and then eventually that stops. We might be able to move into an area where we can control the heat loss, or we move into an area where it's increased because we're outside and the wind is blowing and we don't have protection or shelter. Also, if we can wear the appropriate clothing. Hypothermia is the temperature becoming low in the human body. The core temperature falls below 95 degrees. Remember, we're around 98.6 degrees, so 3 degrees or so really isn't that much. But the body loses its ability to regulate its temperature and generate body heat. If left in this condition too long, the key organs, such as the heart, begin to slow down and our mental status deteriorates. Eventually, death could be the result. The temperature outside doesn't have to be freezing for our patients to suffer from hypothermia. People at risk for this are the homeless people or those whose homes lack adequate heating. Swimmers can suffer from hypothermia by being cold and then coming into an environment that is cool or wind is blowing by. Again, that uh, wind blows off and takes away the heat. Geriatric patients, pediatric patients, and ill individuals can also suffer hypothermia. I had a patient one time who was in her late 70s. It was August. The temperature outside was in the 90s. She had slipped in their bathroom, getting out of the bathtub, slipped and fell and had broken her hip. She laid on the floor for almost a day and a half, we figured, until her granddaughter came to check on her. She was severely hypothermic when we arrived on scene. The hospital said her core temperature was around 90. Um, she was still somewhat responsive, but certainly, um, even though the temperature outside was nice and warm, she was inside. She had been in the bathtub, and, and she suffered an injury. Some of the signs and symptoms of severe core temperature are here illustrated in this chart. We see that at between 93 to 95 degrees, shivering and foot stomping starts. Below that, 89 to 92 degrees, there's a loss of coordination, muscles stiffen. We see slowing respirations, the pulse slows, patients become confused. Lower than that, we have coma and then apparent death. And it is true what you've heard before. Your patient cannot be declared dead until they are at least close to normal body temperature. We do rewarming. So use the back of your gloved hand to assess the patient's abdomen. Remember, the core stays warm longer than anything else. So that's where we want to check to see if our patient is hypothermic or cold. We saw these numbers in the chart on the previous slides, but never assume that a cold patient whose pulse is dead. We do rewarming, CPR. Cold injuries can also result in localized injuries such as frostbite, and here's some examples of that. Again, we don't think about that being a big problem here in the Pacific Northwest, but when I was 17 years old, I was hunting with my now brother-in-law and didn't have any gloves. It started to snow. We were out for probably an hour and a half or so. My hands froze to my rifle, and I suffered from some mild frostbite. To this day, I have some damage, uh, very sensitive to temperatures in my hands. So things we need to know is how long was the patient exposed to the temperature? Um, where were they exposed? What was the wind velocity? Because remember the whole wind chill chart factor, it actually drives the relative temperature down, and that's what it feels like to our person. Are they wet? Were they exposed? Do they have adequate insulation from the cold? And some other underlying factors that maybe we don't think about sometimes are clothes too tight or shoes too tight. Poor nutrition, alcohol, drug abuse. This goes back to perhaps some of our homeless population who have a large number of them are abusing both drugs and alcohol. Do they have medical conditions such as diabetes or heart trouble? And then what is their age? Frostnip and immersion foot. If you ever an opportunity to read up some stuff on World War One, immersion foot, or what is commonly called trench foot, was a huge problem in the European theater, particularly for the soldiers being stuck in the trenches filled with water and such, and it just essentially ate away at their feet. So prolonged exposure to the cold can freeze the tissue and perhaps even lead to more serious uh, um, types of injury. Frostnip, or what we might consider like a first degree uh, frostbite. Usually it's not too painful, um, and your ears get cold, they kind of freeze a little bit. You go inside, you warm up, and you don't really feel much of it. We talked about immersion foot a little bit, prolonged exposure in cold water. Hikers and hunters get it. They're walking through, tromping through the woods. That's why when I've done any hiking long distances, uh, perhaps many of you have, I always bring 2 or 3 pairs of socks so that I can change. So frostbite itself, more serious. I noticed the discoloration. It can also be a reddening color, maybe even it turns a waxy or white color. Um, think of this almost like a burn to the hand or extremity, um, much like we would think about burn injuries, only it's caused by cold. A similar process is happening. Cells are bursting and freezing inside of the tissue. Um, if they get like this illustration or like this picture here, have gangrene, then it might be necessary for them to have parts of the dead tissue removed surgically. With superficial frostbite, only the skin is frozen. It's kind of, again, like a superficial burn or a first degree burn. The deeper it gets, the more tissue is frozen, the more serious it gets, the more debridement needs to take place, the more damage is done to the patient's extremity. So as with all incidents, we want to make sure that we've done our best to do scene size up. Um, we need to make sure that we're not part of the problem. Are we working on icy roads, mud, or wet grass, anything like that? It's kind of embarrassing and certainly very dangerous if we get out of the ambulance and we slip and fall and hurt ourselves because we didn't take the proper precautions when we got on scene. We do our assessment just like normal. Is there a life threat? Then we treat it. We seize their mental status. If they're a patient, if the patient is in cardiac arrest, we start CPR. Do our best to remove them to the warmed ambulance so that we can work on them there. Give them warm oxygen. Maybe we put some hot packs in their behind their neck, in their armpits, and their groin to help rewarming techniques if necessary. The American Heart recommends that CPR be started on a patient who has no discernible pulse or is breathing in the presence of hypothermia, and continue CPR until that patient has been warmed to a normal temperature. We need to be careful with our patient when transporting them. As they start rewarming, we don't want ice crystals uh, floating around causing damage to other organs, and particularly the heart. Do our sample history, find out how long the patient has been outside, um, what were they like before it happened, etc. Remove the patient from the cold is always the first thing. Get their cold and wet clothing off of them. Cover them up with dry, warm blankets. Um, in the wintertime, it's hard to do this. If we're going to a house or we have the ability, perhaps we can stick a warm blanket or a blanket in maybe our IV warmer, or if we're at somebody's home, we could put the blanket into the dryer for a little bit while we're getting ready to move the patient to the ambulance. Rule of thumb, if you need to wear a coat or a sweatshirt, your patient needs at least 2 or 3 blankets. And if we're using these thin blankets that we get from the hospital, you might even double or triple that amount. Give warmed, humidified oxygen if available. Don't massage the extremities, don't rub them. Think about each cell as it's crystallizing because it's cold and freezing. You ever look at meat when it's been in the freezer? You look at it and it's got like these little crystal things on it. Those are ice crystals. And if we were to rub or massage the patient's extremity, it's almost like there's tiny little shards of glass or knives that are cutting and destroying those cells. So we don't want to cause any more damage by rubbing, um, even though massage seems to be one of the things that an intuitive type of way of warming somebody up. This is actually contraindicated. In the case of mild hypothermia, our patient may be alert. They might be shivering and responding appropriately. So again, we want to place them in a warm environment, remove any wet clothing, heat hot packs or hot water bottles in the groin, armpits, and behind the neck. Again, don't try to actively rewarm their patient if we cannot guarantee that we can keep them in that condition until we get to the hospital, including having to remove them from the ambulance to go inside of the hospital. So it might be best just to cover them up with blankets, do our best and to prevent heat loss and them getting colder. Always remove wet clothing and cover them with a dry, warm blanket. Handle the injured parts gently. We don't want to cause any further damage or injury. Remove all wet, constricting, restricting clothing for the injured part of the patient. Do not re-expose the patient to the cold whenever possible. That goes without saying. All these other things in the slide we've heard already before. Remove any wet clothing. If we're going to rewarm in the field, we need to immerse the frostbitten part of the water between 102 and 104 degrees. So then we would have to have a way to keep it that relative that temperature, etc. In the Pacific Northwest, yes, it's true we have cold injuries, particularly on the east side of our state in Washington. Um, they deal with more severe temperature fluctuations than what we have here in the Puget Sound area. Follow your local protocols if this is something you're going to try. But if you're working in the Midwest or areas where it does get really cold, upstate New York, etc., those places, Eastern Seaboard, um, this might be something that we need to consider. And then, are we, the rescuer, at risk for hypothermia if we work in a cold environment? Do we have the proper PPE to take care of a person? Do we have somebody immersed in water? Are we wearing a survival suit? Do we have that training? Have we taken necessary uh, measures to have yak tracks, for example, on our shoes so that we don't slip and fall? Are we wearing appropriate clothing for the environment and for the temperature that we're at? These are all questions we have to ask ourselves before we go on to any call, but especially those that are weather related for cold exposure. Switching gears now, heat exposure. Now, again, it doesn't get as hot here in Washington State, at least on the east or west side of the mountains in the Puget Sound area, as it does in some other areas. But we do have patients that we see frequently from heat related emergencies. One of the things that happens here is it's like 40 degrees one day and then 70 degrees the next day. Or in the summertime, it could be 50 and then up as high as 90. And so our body doesn't have a chance to acclimate to that heat. And that's where we get relative heat exposure. Hypothermia, by definition, the core temperature reaches in excess of 101 degrees Fahrenheit. Um, so, again, some of the things that can be risk factors. It's hot out, it's high temperature, it's in the 90s. High humidity, because that reduces our ability to perspire. We don't have, I mean, it gets humid here sometimes, but not like it does in other places. For example, my wife grew up in Charleston, South Carolina, and it gets really humid in the south, eastern seaboard of the U.S., much more so than it does here. When they talk about 80 to 90% humidity, where you feel like you're walking around in in moist air that's hot, that's where we have the inability to evaporate or perspire and cool ourselves that way, and it becomes very difficult. So that's where we can have some stuff. Notice the population that has difficulty dealing with heat-related illnesses, very similar to the population that has difficulty with cold illnesses. But we're going to add a couple of people to that group: heart disease, patients who have COPD, diabetes, uh, dehydration, and obesity. And of course, people who are limited their mobility, they don't have the ability to walk around and help cool themselves by just moving. Stroke. Heat stroke is the least common, but the most serious. It occurs when the body is subjected to more heat than it can handle. It can't. Its normal mechanisms are overwhelmed. It can't cool itself. We've lost the inability to perspire, and if untreated, the patient likely will expire. So sometimes this happens. We're working outside. It's really hot, poorly ventilated areas, humid spaces, heat waves. Again, we don't have a lot of that here, but remember, it's we do have the rapid change sometimes and how quickly it gets. So we could get a relative type of heat exhaustion or heat stroke here. Um, Kids, pets left in cars that are locked in the hot sun with the windows all the way up. And rolling the window down just a little bit really isn't going to do much to help the patient and help the heat to get out. So don't leave your kids in the locked car unattended. So what do we do for heat cramps? Well, remove the patient from the environment. Have them lie down. Give them sips of water, and cool the patient with moist water or spray mist, water spray or mist. Just gently cool them off. Um, so with heat stroke, very similar. Put them in the, get them out of the environment, put them in the ambulance, turn the air conditioning on, remove their clothing. Maybe we put a cold pack under their armpits or behind their head. Um, we have to ventilate them. So look for other reasons why the patient might not be doing well. What's their blood sugar like? What other reasons could they be altered with their mental status? Drowning is something that we do have here um, quite frequently in the greater Puget Sound area. Just in Kitsap County, for example, or central Kitsap in our fire district, we have 45 linear miles of saltwater beachfront just in our area. We have numerous lakes and streams and creeks that run through our area. Um, all of these are potential causes or possibilities for somebody to suffer a drowning or immersion injury. Um, the weather gets nice. People like to go out. They like to play by the water. They like to ingest a couple of beers. They get feeling good. They go swimming, and they could drown. And of course, that's just one thing. Unsupervised access to water, whether it's, we talk about it with children, but if you're out with your friends and you're having a few beers and somebody goes in the water and somebody else isn't paying attention, that could be considered unsupervised also. So with immersion injuries or dive injuries, we need to worry about or be concerned about spinal problems. When did they dive in and hit their head on the ground? They have a long fall or cliff diving or jumping off an area. We used to have this area when I was a kid up in Bellingham called Watkin Falls. People would climb up these cliffs and jump into this pool, and it was a lot of fun. And I think now, I don't know how we didn't get hurt. I mean, seriously hurt. Um, you know, so any suspected spinal injury, we want to stabilize the patient while they're in the water, and then remove them from the water. If you are not trained as a water safety person like a lifeguard or a rescue swimmer do not go into the water to get a patient. Practice instead the reach, throw, row, and then go statement. If you are not trained, you may not be able to take care of the patient adequately and properly to get them out of the water, and you yourself could become a victim. Never give up when trying to resuscitate somebody from cold water drowning. Now, there's some theories as to how cold does that water have to be. The Puget Sound roughly is between 55 and 58 degrees, um, depending on which literature you read. Some say it's less, it's colder than that, with the high temperature being closer to 57 degrees, um, which still is really cold, and we can't stay in the water for very long um, without suffering from the ill effects of the cold water. But is it cold enough to be quote unquote cold water drowning? Depending on what you read. But uh, attempt resuscitation, begin CPR, and transport. So descent injuries, as they relate to diving, person goes down too deep. Um, the pressures don't equalize. They're not clearing themselves as quickly as possible. I don't know much about diving, um, but I know that we have to equalize, and I think it's 14 feet down is another atmosphere, so the pressure increases, and we have to maintain. Uh, we have to balance ourselves out um, as we go down. Some of the problems that could result are inner ear damage. We could rupture our eardrum. Um, some of our organs could be ruptured. Hollow organs could be ruptured. So, as it says, emergencies at the bottom, they rarely occur. Inadequate mixing of oxygen and carbon dioxide. For people who dive at great depth, they um, do stuff to their gas to mix it so that it's easier for them to breathe. And so we need to keep that in mind as we're bringing them up, should we be part of that team to do that. So ascent injuries, we might see that. I've been on a couple of those in the area where somebody has, popped to the top a little too fast, almost like a cork coming out of the water. Um, just as it is important to slowly acclimate to the atmospheres as we go down, it's equally as important that we slowly uh, acclimate to each atmosphere as we come up to allow our body a chance to um, remove and equalize the pressures within our interstitial spaces and such. Air embolism is one of the most common things that could happen. Um, a type of dive injury, and imagine if that gets into your circulatory system and it gets into your heart, that could cause cavitation, and then the heart doesn't have any water or blood in it, and it stops working and fibrillates. Um, we also have conditions such as the bends, um, nitrogen or decompression sickness, as I mentioned here, bubbles of gas, especially nitrogen, that get into the blood system. So, and some of the different things that could cause that. Should it become significant enough, and we can't determine whether or not there's an embolism or decompression sickness or the like, then we're going to give them high flow oxygen. We're going to transport or have the patient later transported to a decompression. And in the Pacific Northwest, Virginia Mason Hospital has a decompression chamber that can hold up to, I think it's 5 patients Um, there's some various other places around the community that maybe can hold one or two, um, but I know that Virginia Mason has one that's available most of the time. They usually have a tech that they can call in by the time an ambulance would get there with the patient. If they have an air embolism, we get the patient out of the water, we keep them calm, we give them oxygen, we consider possible other causes, monitor breath sounds, and take them to the hospital. Pay close attention to other hazards. Now, we just talked about some of the injuries that could result there. Trauma can also happen on the water too, with boating accidents, um, dive emergencies. Boats can run over each other. Boats can run over, you know, personal watercraft, etc. And then there's those who are like free divers, breath holding syncope. You know, they dive down without any oxygen or without any air or anything. Um, and then and some of these people drive down or dive down really crazy depths, just holding their breath. The downside is, if you ever held your breath too long, sometimes you can pass out, and if you do that underwater, that could be a bad thing. So always take appropriate precautions to prevent any of these types of immersion incidents. For you as rescuers, make sure that we're taking appropriate precautions when we're working in and around water. I can't speak for all agencies. I can speak for the one I work for. If we are in or around or over water, we shall wear a personal protective, a personal flotation device, a PFD. So with high altitude, there's also issues that we can have here, whether you get high altitude sickness or uh, various other things. This has happened sometimes. We think about people who are ascending like K2 or Mount Everest or some large mountains, but it can happen if you're just going up and coming down too fast. Went to Colorado Springs a few years back. We drove to the top of Pikes Peak. We hung around down at Pikes Peak for a little bit, and then we came back down to the city of Colorado Springs. And just that going up and down and that change in pressure and how quickly we did it. Um, we all had a mild case of altitude sickness, headaches and the like. So acute mountain sickness is another condition caused by ascending too high and too fast, and then perhaps returning back to your um, previous atmosphere too fast. High altitude pulmonary edema can be a collection of fluids as the body's trying to overcome the pressure change, but it just kind of blows out into the system. And then you can have high altitude cerebral edema where a similar thing happens. The body is trying to balance the shift in pressure changes and the fluid in the interstitial space and intercellular space has to go somewhere, and it winds up going into your intracranial or into your near your brain, and then you get a type of cerebral edema. Lightning strikes can be super scary. We've had a couple of lightning strikes in our area that have hit, fortunately, buildings and not any people. Um, but we've had, some, here's some that you see that are, potentially dangerous. for boaters, swimmers, golfers, etc. Anyone in a large open area during a lightning storm. Um, Fortunately, we don't get them a lot here, but we do have them with some regularity uh, in the fall and sometimes in the late spring. So be cognizant of this. And if your patient is struck by lightning, make sure that we get them out of the environment and then treat appropriately. Perhaps we may need to be doing CPR, defibrillate them, etc. So commonly, cardiovascular nervous system problems happen. One of our guys that works for Central Kitsap when he was 13 or 14 years old was struck by lightning while he was watching a soccer game. He was resuscitated. He was in cardiac arrest when the medics showed up. He was resuscitated, obviously successfully, and he's one of our firefighters today. So quick action needs to take place in this, but we also need to make sure that we remove ourselves from a potentially hazardous environment, as it says here. So now we're going to talk about spider bites and other things that are creepy and crawly. Spider bites, there's tons of spiders, and we have a lot of spiders in Washington State, and we have some that uh, are here that people don't think are here. Some are life-threatening, some are just uncomfortable, um, and some are just really icky looking. So with the black widow spider, it is only the female spider is the bad one, and it's called the black widow because it mates and then it kills its the male spider. Um, but really, they're the only two really serious ones in the U.S. The black widow and then the brown recluse. And they say we don't have brown recluse here, and we do have brown recluse here. I got bit 17 years ago by a brown recluse spider, and so we do have them here. So here's a black widow. Notice the hourglass shape on the abdomen. Um, and so try not to come in contact with it. It's a spider. They're gross. Like most spiders, they prefer dark, dry places. And sometimes we don't recognize that the person got bit. It's got a very dangerous neurotoxin, so we need to be careful with that. But generally, it goes away within 48 hours. Good BLS care is usually what's necessary. And then, if possible, I like that. Bring the spider. Well, I will bring a photo of the spider if I can do that, and it's still able to be recognizable in the photo. Brown recluse. They say it's got a little violin-shaped mark on its back. Mostly live in the southern central parts of the country, but things like to move. Comes in on shipped in here. There is, from what I understand, a colony of them on the Erlands Point area in Kitsap County, and they have migrated to other areas. So we don't want to just say, oh, they're not here, because they can be here. Powerful neurotoxin. They like to live in, or excuse me, cystotoxic. They like to live in dark, damp, or dark areas also. Um, and the the bite isn't painful, and it's a couple hours later, it gets all swollen and tender, and it starts changing colors, um, and then it's very painful after that. And it can cause necrosis of the tissue. Um, with good, quick recognition and treatment, the patient can survive without any lasting effects. But left untreated, it's possible that they may have to have part of their tissue excised or even removed. And then, of course, all things that's fly and sting, bees, wasps, yellow jackets, ants, etc. Um, so they'll sting. Some will leave a stinger. For example, like the honeybee or bumblebee will leave a stinger. Um, and the venom sac will be in the stinger, so we need to not squeeze it or pinch it when we remove it. So we wipe it off. We carry stuff called sting kill, which is like a fancy alcohol prep pad that you open up and you put over, and you wipe it over, and it grabs the stinger and takes it out. So snake bites. So I just think snakes are gross anyway. Anything that can move without legs or feet is just it just. Ugh. But so again, maintain a professional composure when dealing with this. There's about 115 different species of snakes, and only 19 of them are venomous, which is nice. Um, in Western Washington, we have no snakes that are venomous that are from here, that are indigenous to Washington, Western Washington. That doesn't mean we don't have them here, but they're not native to this area. So we do have rattlesnakes in eastern Washington, and then other areas of the country have some of these other great, wonderful snakes, such as copperheads, cottonmouths, water moccasins, coral snakes, etc. When I look at a picture of a snake and they tell me, oh, whatever the Boy Scout thing is, red on yellow and black on whatever, it's a snake. I don't want to get close to it, and I would suggest that with you as a first responder, unless that is your occupation and or you know everything there is to know about the different kinds of snakes. I probably wouldn't encounter them or engage in them. Um, it's just not safe because I don't know which one's good, which one's bad. Of course, the one in the upper left in this slide is rattlesnake, and typically they only rattle when they're startled or when they're ready to strike. But I guess they have also evolved so that they don't always do that, so you never know. So just be careful. Um, Most snakes don't usually bite unless they're provoked, but what is provoking? So make sure we're always wearing a proper PPE. Are we wearing boots? Do we have gloves, safety glasses, etc.? Um, we don't have a lot of cobras that live here, but cobras will spit their venom. So another reason to wear safety glasses on all your calls, just in case you come into contact with a snake. So the most common type of snake that we see in our area, um, rattlesnakes in eastern Washington, are pit vipers, and they're called pit vipers because you can see right in front of the eye there's a little pit, and that's why it's called pit. And then they've got the fang and the venom sac. And so rattlesnakes are the most common form of pit viper, and they can grow up to 6 feet or longer. Last summer I was in Texas, went to a museum, and they had some stuffed rattlesnakes, and one of them was almost as big around as my leg, and was probably 12 feet long. Had it on a wall mounted, and it was just like holy smokes, huge. So big snakes, gross. Copperheads, as it says, their bites are almost never fatal, but it can cause tissue necrosis, damage to the tissue, etc. Cottonmouths, um, the tissue destruction can be fatal. They have different that are extremely not healthy for humans. So try not to get bit by a snake. If you do encounter a patient who has been bit, um, it might hurt. Could be swelling. There could be some cyanosis around the site. Um, we used to teach that you band it and you'd cover it and then you'd cut it, and we had these little things that you'd try to suck the venom out. We take them to the hospital. We treat it like a wound. We know that they have something in it. We take them. Coral snakes, they can be not healthy. They like to bite you on the toe or the finger because they're a smaller snake. They have a very powerful toxin that causes paralysis of the nervous system and can be fatal. So we need to do that. Antivenom is available, um, and probably more so in hospitals where this could be a problem, but it might not be available. I mean, somebody were to get bit by a coral snake here in Washington, maybe University Hospital because they're a research hospital would have it, but I don't know. I don't know where you could find that. Emergency care is the same for every pit viper bite. Right? Scorpions and scorpion stings. We don't again have scorpions that live here. They like more arid southwestern areas, Arizona, New Mexico, that kind of stuff. But that's not to say that they can't hitch a ride in on a vehicle and wind up here. So stranger things have happened. Right? The scorpion sting is painful, from what I understand, but it's rarely dangerous. There's a good picture of what it looks like, kind of like a land-dwelling lobster. Ticks. Now we have a lot of ticks in Washington State, and we have different kinds of ticks, and I couldn't tell you which ones they were, but um, they like to, land on people, and they can cause some significant. Some ticks can cause Rocky Mountain spotted fever, um, and that happens like 7 to 10 days after the patient gets bit, and it could be, cause weakness for the patient. Lyme disease. Lyme disease, again, bullseye looking rash comes around. It gets all over the body. Might not happen right away. Often it's confused with arthritis. I looked up some information on Lyme disease a little while back, and it like they don't have a cure for it, so it could stay in your system forever, and not you wouldn't even know you had it until later on. So go camping and hiking, it's important to check yourself, make sure you don't have ticks. Um, so wear proper clothing when you're out there, hooded sweatshirts, that kind of stuff. They like to get on animals, your dog, if you hike with your dog, kind of stuff. Long hair, etc. So if you're not sure how to remove the tick, try not to. Then go somewhere where you can have it removed. When it says remove it with using fine tweezers to grasp the head, you have to get the head out. You can pull the body off of the tick, and then um, it could, the head is still there, and that's where the toxins are. So um, do your best to clean the area. So best for you as a first responder not to try to remove the tick, but this is good information should you encounter a tick yourself. We also are surrounded by saltwater in this area, the Great Puget Sound in the middle of our or part of our state here, and then of course the Pacific Ocean. So we have a lot of critters out there that can cause some problems. Um, Stings, some of them are uncomfortable, some of them are can be deadly, such as the Portuguese man of war that can be very deadly. Here's some of those sea anemone here, and then the man of war, and then this is a moon jelly. They have a neurotoxin that kind of stings. It's uncomfortable kind of stuff. Um, so as I said, there's a lot of stuff in the environment. that can hurt us, but if we take care of ourselves and pay attention, then we can be protected. And we need to make sure that we're protected when we're taking care of our patients, so that we can do the best job that we can. Thanks.